Good evening, everyone. First of all, again, thank you so much for inviting me. It's a pleasure to be here. My name is Nadia Allen. I'm the Executive Director of the Mental Health Association, Orange County. And in addition to doing that, one of the very important works that we do in our community, a lot of executive directors, a lot of people in positions of leadership, I think one of our responsibilities to our community is to really engage the community, try to give back to a certain extent. And one of the things that I do, we started in our county, the Cultural Equity Task Force. So I'm going to pass this around to you because it's kind of the work that we do. And basically it's a group of human service providers and family members and individuals in the community who are recipients of human services. To have access to knowledge and understanding of oppression and understanding the fact that every culture has the right to develop, to thrive, without us having to...
Excuse me, we cannot record you.
Excuse me?
Oh, yes, we need
we need
mic because...
Okay. So can I speak over here?
Oh, yeah.
Sitting down. Because, it is the right of every culture to thrive in an environment free from oppression. So the work that we do at the Mental Health Association, I think that's very important for a human service provider, is to make sure that we look through the work that we do through the social lenses that we need to have every single day. And the reality is, if we don't see the person for who or she is, independent of their background, independent of where they came from, independent of their experiences, if you don't see them for who they really are, we cannot really support them in their recovery. So cultural equity, cultural competency, cultural and linguistic competence is very, very important in the work that we do as human service providers and very important in the work of mental health. And I just have to share with you that I'm from Brazil, and English is not my first language, but I do speak Portuguese, a little bit of Spanish, and I do speak English. And I think it's very important also to understand that not everyone who comes through the doors in terms of mental health services are going to be completely eloquent, and we are very much in the process in our community, and I see in New York City a lot more, and I'm very proud of the work that you do here, to have all kinds of supports in terms of optimal language services, because it is the makeup of our country, and I look in this room and it makes me warm inside to see that we represent the people that I serve, and this is very exciting for me. The other piece that I want to share with you is I was very happy to be invited to be here today, and I have spoken in women's forums before, but I come from Brazil, as I said, which tends to be a very sexist, patriarchal, misogynistic country, and that has made some progress over the years, but not significantly so. And when I moved to this country, I found that there is oppression against women, but it's on less and smaller scale, although it's there, alive and well. But it really made me stay and be able to bring some of my experiences back to my country and do some projects on a voluntary basis to see and bring some of the progress that we have made in this country into Brazil. And we're getting there, but we have a long ways to go. But I do have to say that I come from a family of mostly males, very sexist, patriarchal males, but also very strong women in my family. And I always say jokingly, but it's the truth, my mother was the first person who shared with me and expressed to me the importance of the F word, and that I mean feminism. So it's really important that you know that. Okay, now, mental health. We talked a lot about the statistics, we talked a lot about how it impacts women. And the reality is, in the work that we do, looking through the social justice lenses, we have to look at the privilege that all of us bring to the table when we arrive for services, right? So although I am a woman, and I don't fare as well as males in the way of accessibility to services, in the way of my wages, in the way of the burden that I have at home, because the reality is, in a study done in 1989, women, once they took over the role of, non-traditional role in the 70s, 60s, 70s, and 80s of going out and working outside of the household, they did not decrease their workload at home. Males, on the other hand, when we went out and started working, the males did not take the non-traditional roles and did not necessarily start taking care of the household. Granted, I'm talking globally, but the reality is women work an average of 5 hours extra per month, over a month longer than males if we were to count our daily work, paid work, and your non-paid work. We're more likely to be those individuals that not only take care of the household, the children, the pets, the grandmother, the grandfather who is ill. And what does that do to a woman? What does that do to a woman? How does that impact our mental health? We're working, some claim, twice as hard. We are dealing with a tremendous amount of issues that are very emotional because we're dealing with people, we're dealing with the realities of daily life, we're dealing with routines of caregiving. And those are very stressful things. We're dealing with postpartum depressions. I mean, the fact that if that's left untreated, it can lead definitely to very, very dramatic outcomes. So we really have disproportionate representation in our mental health system, particularly around the depression, because PTSD, as it's been mentioned, as you all know, it's much more prevalent in women, and particularly because of the violence. It's simple as that. If you were to eradicate violence against women, post-traumatic stress disorder in women would decrease significantly. It's just that simple. And when I look at International Women's Day, as you know, it started in, I think, 1911, but in 1975, the United Nations started with themes for International Women's Day. And I kept looking at the themes from 1975 to 2013. And there are 7 or 8 of them that it speaks about violence against women. Violence against women in 1999, ending impunity for violence against women in 2007, women and men united to end violence against women and girls. A promise is a promise, time for action to end violence against women in 2013. And that saddens me. It makes me happy that the United Nations is really putting that out there as an epidemic, but it saddens me that we're still talking about this. It saddens me that violence against women is still allowed, and it happens, and it's perpetuated, and perpetrators, by and large, get away with it. So I would like to see us not talk so much about violence against women someday, but I would like to see in the United Nations to have something that John Jay is doing today, to have a theme that talks about gender bias and its impact on mental health, or how you call the mental health effect of gender inequality. So that's very important. When it comes to mental health, one of the things that I can speak to you that is a little bit differently than my colleagues have spoken here today is the fact that we provide very, very direct services on a daily basis to those 2% of those severe psychiatrically disabled folks that we talked about. And the reality is we are dealing with, by and large, public health. A lot of the folks that we serve are individuals who have a disability that's chronic, and we do deal with a tremendous amount of women. And they come to us with a history of trauma, and that's true with most people that we serve. Trauma is at the core of their mental health disorder, and we do train all of our staff, and you'll be happy to hear that, Miriam. We train all of our staff in trauma-informed care and strength-based approach because we believe it's the only way to serve folks. And they come to us broken. They come to us if they are parents, they don't no longer have their children living with them. There is a law, believe it or not, they were trying to move in the public policy level that if you are a parent, a mother, and you gave birth to a child and you have a mental health disorder, there is a good possibility they're not going to go home with your baby. So what is the likelihood of a mother disclosing that she's ill, that she's mentally ill, when you have the possibility of not going home with your baby? And if you seek help and you have children at home, you have the fear that you're going to lose those children. Now ask me, how does gender inequality impact your mental health? Males, they do not necessarily have that concern because most likely they have a woman at home taking care of their children. But somehow that burden falls on us as women, and we have a tremendous amount of fear to come forward. Stigma is huge, we know that. And so coupled with, the laws that are not necessarily very supportive of women, women do not necessarily seek for their help. And they come to us very broken. We deal with sexual assault. We are the only sexual assault provider in our community, so I could talk about that for the next 20 years. The crimes that we see committed in our community, mostly by intimate partner, the kind of mystique about, the person that jumps out of the bushes and attacks a woman is completely erroneous. That's most of the time is your intimate partners. And I cannot tell you how often they happen to be people from our own community, people that I know, people who hold positions of high power, and that we have a very difficult time prosecuting in our district attorney's office. So those are the politics that we deal with every day, the oppression that we work with every day, that we try to move forward the agenda of women. What we do in our agency, we make sure that we address the needs of women in several ways. We have a unique program called the Invisible Children's Project. What that does is make sure that the family unit is kept intact, so the mother feels comfortable coming to us and seeking help. That the mother feels comfortable saying, listen, I do need support, but I want to keep my family unit together. Because the reality is, folks, mental health is no different than physical health. We have one body. From the neck up is no different from the neck down. The brain is an organ the same way that the heart is. If the heart doesn't function, if you have a pancreas that doesn't function, you go, you get your insulin, you take care of yourself. If you have a mental health disorder, it's the same way. The misnomer that mental health disorders are not treatable is not, it's a misnomer, that's all it is. Mental health is treatable. There is recovery. And we have to believe that. And we have to seek the help and we have to go for it. And the reality is, once you treat the brain, which is an organ, right? It can function. There is no shame. No shame. The same way that you have no shame saying that you have, to take insulin to take care of yourself, there should be no shame about saying, my goodness, I need to take this medication, I need to go to my psychotherapist once a month or once a week. But unfortunately, there is that stigma. That's why one of the things that we move forward in terms of public policy is making sure, and Dr. Rahman alluded to that, making sure that we combine what we call and provide integrated health care. The majority of the folks that present in emergency rooms, the highest users of medications in our country, Medicaid services in our country, they present in the emergency room for reasons that they present to be medical. But most of the highest Medicaid users in our country have an underlying mental health disorder. That's a fact. So in our agency, along with a lot of the New York State and the Medicaid redesign team approach, we have developed what we call health homes, and we provide care coordination. Basically, this care coordinator is not only a mental health provider, but somebody who is trained in a lot of health issues. And he or she is able to link this person to services, and we have a portal that we're able to access all the providers that the person has touched, and we communicate with each other. We make sure that that person receives the services that he or she needs. And what does that mean? We want to make sure that folks are out of the hospitals. Institutionalization doesn't work. We have deinstitutionalized, we put people in the community, but we did not provide the funding to take care of folks, so that's the other public policy agenda that we work on very hard in Albany and Washington, D.C. We closed these hospitals, we realized a tremendous amount of savings with the psychiatric hospitals, we realized a tremendous amount of funds in terms of savings, but they were not reinvested in our community. So we work with that and we fight for that every day, because those dollars should be right here in order for us to make sure that folks receive what we call the community integration, the community-based services in terms of housing and peer supports and family supports and support groups and vocational service, education. So women, again, are disproportionately impacted because naturally males not only if and when they access the services, they're still getting paid, we're still getting paid, as I said, 77 cents to the dollar, so we have the glass ceiling. So there are so many things that are particular to us as women that keep us in a place of underprivilege. So we need to integrate healthcare. We need to instruct primary care physicians. A lot of the work that we do is really instructing primary care physicians and nurse practitioners about the screening for mental health disorders. So, and we also have a tremendous amount of work done with families family is a huge piece of supporting the individuals that we serve, and a huge piece in supporting women. So we work very closely. We have family support services. We have a tremendous amount of educational opportunities and vocational opportunities in order to ensure that women receive the services that they deserve. And of course, we work with men, and we work with a lot of men, but today, of course, my emphasis is on women. So I know we're limited in time. I don't want to go on anymore, but I have information about the work that we do. Just out of curiosity, for those of you that are students, those of you that are part of the community, there is a mental health association in New York City. There are mental health associations all over the country. It's about 260 of us. If you've seen one mental health association, you've seen one mental health association because we represent the needs of the community. And why the sexual assault is with mental health association, we get asked that all the time, and I'm sure that's one of the reasons I'm in this panel, because there are very few mental health associations that have sexual assault services. And the reason that we do is because we respond to the needs of the community. And there was a need for sexual assault services in our community. And because sexual assault results in severe mental health disorders is the reason why we need to make sure that we were there, part of solving the gap in the services in our community. So I'm very proud to be here. I learned a lot today, and I look forward to your questions. Thank you very much.
The question is for Ms. Goodman. In regards to the victims that you encounter, how many victims go back to that lifestyle in regards to prostitution independently away from the pimp?
That's a really great question. So I meet people across the spectrum of having never had a pimp to currently having a pimp to have had a pimp and now don't, but are still involved in sex work, prostitution. And I think the reasons for that vary. For people who were first turned out or introduced to this world through a pimp, and it's usually at a pretty young age, you might not have what many women have said is it's what I know to do, you know. So there's not they don't have their education. They probably have a pretty extensive criminal record. Prostitution in New York is a misdemeanor charge. So you end up with a criminal record and a very stigmatized charge that is on your record as well. So for a percentage, I don't know. That's a good question. But a lot of people it's a struggle to make change and leave a lifestyle and a person in particular. Sorry, I don't have an actual number, but yes, it happens a lot.
Can I just say something to that? If I could just say, we talk about lifestyle, and it is, unfortunately, a lifestyle, but I think it's important to understand for us in the sexual assault arena, which we do deal with a lot of women who are trafficked, I never know how to say that, is the fact that lifestyle implies that it's a choice.
Right.
And unfortunately, for a lot of these women, the choice to have been sexually assaulted, the choice to have been raped is just not, a victim of traffic, it's not a choice. And to get out of that oppressive stage is so difficult. And I think one of the things that we struggle with the most is the fact that there is this expectation that can you just snap out of it now? You receive the treatment, receive the services, your perpetrator has been put away. Can't you just now get back to your life? It's completely changing and shifting the way your mind works. And there is such control of your past into your present that it's very hard to move on. So the recidivism, if you were to call it, rate, I'm sure it's still pretty high.
Yeah, recidivism is definitely high in that population because, change is a process, it takes time, and I completely agree with what you were saying, and choice is just really complicated. Even if there isn't an actual person forcing you anymore, again, if that's what or there isn't other options, a lack of other options. Choice is a very complicated thing. And just in the similarity to domestic violence, they say it takes, 7 times an average for a woman to leave a perpetrator. When the trafficker is an intimate partner as well, or an intimate person, it takes, we don't have a statistic yet, but I imagine it's something very similar to that.
Can I just add one thing on this whole issue of we talk a lot about issues of prostitution and sex work just solely in terms of individual choices and how to make people make choices. One thing to keep in mind as well, that prostitution and other kinds of sex work are economic issues. And so oftentimes the reason people enter into sex work or enter into relationships that bring them into sex work is because there is no other economic option. And so that's one thing to keep in mind, that, yes, obviously these issues of past trauma are very important, but there are also structural issues. And if you don't have another job and you have a criminal record, what is your other option going to be?
Absolutely, and to add to the economics, that has been for forever, a very long time, and I imagine it will continue to be, a lot of money to be made off of women's bodies and sexuality and sexual everything. I was just reading recently in Spain, they're having a terrible economic time, and there's a small group of sex workers who are training other people to be sex workers because there's lots of money to be made. Even in a horrible economic climate, there's still money to be made, and you've got to eat or whatever.
It's the oldest profession.
Yeah, the oldest profession, exactly. That's what the women always say. There's still money to be made by a woman's body, which is, to me, pretty fascinating, for sure.
Good evening. My name is Esteban Rios, and I'm a practicing social worker as well. So one of the questions that I specifically have, asking a question as a man, is as a male social worker, how do you find, and this is for anyone on the panel, do you find any difficulty in really providing the training of, trauma-informed work to, the male service providers who can potentially be working with someone who you don't want to be re-traumatized by that experience of that male worker or that particular, or whether it be a doctor, whether it be a nurse, whether it be a social worker, trying to really work with a woman who you don't want to re-traumatize. And that's for anyone on the panel.
If I can speak to, if I can speak particularly because of our sexual assault program, by nature of what we do, and the perpetrators being 99.9% males, we do not have males working with our sexual assault survivors. It's simply not done. However, every other aspect of our agency it is. And as I mentioned earlier, we made a concerted effort to ensure that every person who comes through our doors, and part of the orientation process is not only to learn about cultural competence and linguistic competence, which is very important. It's the social justice lenses, white privilege, ending racism, empowering women. All those concepts are just common language in the work that we do, but also trauma-informed care and strength-based approach care. And it's part of the orientation. Now, having said that, just because you receive the training doesn't mean they're able to practice it. And we do have a tremendous amount of resistance because it's counterintuitive. One thing that Miriam said that it's very important in trauma-informed care is not, what's wrong with you. Because usually when somebody presents themselves, it's what's wrong with you. It's what happened to you that got you to this place. Tell them about your life experiences. So you have to kind of shift your language. It's a lot of it's like shifting the way you think, the way you talk, but it's constant training and tremendous amount of oversight and supervision that needs to take place because but it's difficult, and I applaud you for thinking that way because that's definitely a problem, and if you do that kind of work, I applaud and commend you.
Yeah, I'm so happy to always meet a male social worker because there's so few, which is so, thank you. I think that, my staff is female, but not because of any other reason for that. Men did not apply for the positions. And I think that, yes, men are likely to be perpetrators of violence, but so are women. A lot of the women that I work with, if you ask them, who pick the most harmful person, it's often mom who didn't do anything or maybe hurt them too or whatever it is, or other women that they know. And so, just because you're a female client doesn't mean that having a female counselor is necessarily the exact matchup. I think it means having some uncomfortable conversations within an agency. I was recently talking with people from probation in a different state, and they brought up a lot of these concerns. How do I ask young women questions to do with victimization? And it means getting uncomfortable with a lot of that discomfort. It's more coming from the person asking the questions than the person that's sitting there. And if you can really incorporate everything that Nadia was saying about those perspectives, I think it's totally possible and a great model. Like there are great men in the world, and so to be a positive, person in a survivor's life is a wonderful thing. There's hope.
Just maybe to bring the sort of developing country perspective into this, I can tell you that it's unfortunately so that very often if you want to have access to women, you need
That's a great
women
point.
workers. So it's really even to just break the access.
Yeah,
And
that's great.
I referred to the Thinking Healthy program in Pakistan, and it was really done by the lady health workers. It was a whole cadre that was trained because women were just not coming for antenatal care or even for immunization of kids because unfortunately the fathers don't bring them in. And so, finally it clicked that maybe it's because there are no lady health workers available, and that's when things dramatically change. So that's a big one. But I would also like to reiterate that one of the biggest, and India is one to say, is the mother-in-law, right? Who's the biggest perpetrator of a whole lot of the violence that happens to the woman, from start with the dowry to her daily, the caregiving, to the complaint, to wanting a son as the offspring. It just goes on and on and on. And so it doesn't at all mean that the women are, completely innocent in this whole scheme of things.
That's great points.
I think maybe to give you maybe some hope, at Human Rights Watch, we have a lot of male researchers working on very sensitive issues. For example, our child sexual abuse report, child sexual abuse in India, the research was actually conducted by a man. And it's something that is counterintuitive and that we did think a lot about before we went through with this. We also would, favor a woman doing the research, whether it's, when it concerns sexual violence, whether it's children or women. But I think it also depends on the rapport with the person, and if that this person was able to make the people very, very comfortable, the children, the mothers, not only for interviews, but also for film, because we had a multimedia component with it. And so I think it also, there is, some hope for men to work in this field. I think it also depends on the individual personality and rapport that you can create.
Hello, my name is Hernan Carbente, criminal justice major here at Junjoy, and I'm also a research assistant at the Vera Institute. I was just wondering, from the whole panel, from an international and a local perspective, are there any suggestions that you may have in terms of, we have these conversations here, but are there any innovative ideas that might be out there right now in terms of how to get this information to the younger populations, that are probably not present here, maybe, in high schools, really educating those populations as to what are these issues, what's going on at an international level, and how they may do something about it on a more local level.
I'm happy to take the international perspective on, and I think, again, I would like to sort of bring up this whole discussion that's taking place right now at the UN on the Sustainable Development Goals, because, violence against women is a big one there. Early child marriage, because that's something we don't talk about much, because, when we talk about adolescent births, because that's something that we track. And one of the interesting things that's come up more recently is that earlier people said adolescent pregnancies were really harmful for the adolescent itself, health-wise. Mortality was much higher. That has not really stood the same test of time. Now the evidence is showing that, yes, it may be slightly more risky, but it's not the way we had built it up. So that's not really the biggest argument against it. But definitely the outcomes for the infant is huge, but it's also that you're denying this adolescent of education, of employment, of productivity, the whole range of things. So, focusing on just, it's not that harmful than to have a baby when you're 16, kind of misses the point, right? So I think early child marriage, and again, I think as students here, you would be particularly intrigued by knowing that 90% of adolescent pregnancies take place within marriage. So here, we all talk of teenage pregnancies as something out of marriage, and so we all hyperventilate. But it's actually 90%, and in which case, like I said, the mother-in-law is in complete control of the situation, and things just go from bad to worse for that girl. So, these are things at the international level that people are trying to change. And the other interesting thing about early child marriage is that 154 countries have actually legislation against it. So it's really the enforcement. It's not because everybody says, oh, we should say raise the marriage age and everything will be sorted out. Unfortunately, it doesn't happen again. So there are all these, layers to it. But I think there are certain mechanisms to take place at the international level to bring up these issues. But then you really have to go down to the country level and make sure that you are able to follow up with the policies, with the, the regulations, with the platforms. Because like I said, very often it's not because people don't want to provide those services, they just are unable to do it. Yeah. And to also bring in different stakeholders because, we've sort of, and this is something again which is interesting, that in India, because it's such a huge country, all the focus, even with the World Bank and others, for many years was to lend to the public health system. And then somebody just went and checked and found out that 80% of the population is going to the private sector. So what's the point of putting so much only in the public? I'm not saying you shouldn't. But so there are all these changes that we have to do in our own thinking and bringing in the public-private partnerships. It's very interesting because that conversation is going on right now at the UN. Yeah. And there are countries that are worried, about bringing in the private sector. Will they be really sort of socially responsible or not? But I don't think we have choices sometimes. We really have to work, just as we were saying about the choices at the individual level. I think we all have to work. I mean, everybody is maybe distrustful of others in certain, so we have to set up the framework to make that happen.
Yeah. Yes, to everything you just said. On a super local level, I think one thing, we're talking about human rights, and that means that it's an entire person with every system in place that they interact with. So one thing that I do a lot is training to agencies that don't work with trafficking victims. That's not what what their focus is. It's a substance use place or a mental health place or a school, and so just that incorporating it into like a thought about victimization and trauma and all those things as like something that everybody in all these different levels you can be mindful of and think about. When you're soon to be in the world of work after being a student, to think about how can we incorporate, if it's possible, like the complicated levels of a human in the different agencies that aren't necessarily specifically about this one thing. Like in health, screening for victimization and for domestic violence has really helped connect victims to advocates in the hospital setting. Not a traditional place where, originally people would say, oh, these are people who should be screening and asking questions as it relates to domestic violence. But because that's now happening in a lot of ERs, there are many more people getting connected to services. So just sort of thinking outside the box of like, how can I bring a human perspective to the work that you end up doing? And I love the VERA Institute, so very cool that you're there.
And can I just end with saying that also the work that's very important to happen in every organization, I believe, and that's the belief of my colleagues, if you don't have a basic knowledge of culture where you work and where you're going to go, and you said one of your concerns is how do you get the message out there, right? I think it's a responsibility of every provider. And it's a responsibility of institutions such as these to really educate folks when they go out in the community to understand basic knowledge about different cultures. The reality is people are going to present to you from all kinds of backgrounds that I started my presentation with. We had a recent situation serving a huge need in our Hasidic community. And luckily, because of some of the trainings that we had and some contacts and key stakeholders in the Hasidic community in Orange County, which is huge, we were able to support the service, to support the family, which is unheard of. The Hasidic community is very insulated and isolated, and they have tremendous mental health needs. There's a tremendous amount, unfortunately, tremendous amount of domestic violence taking place. non-reported sexual violence taking place also. But if you don't understand how to penetrate the community, if you don't understand how to communicate, you're not going to make the first step. You know, you simply don't shake hands. You don't look the male in the eye. I mean, there's so many things that you just have to strip ourselves of our own, secular Western values, and you have to adapt yourself to the needs of the people that come. Because one of the things that we need to keep in mind, particularly in human services, is that we are providing a service, right? And those folks are consumers. If this were, a retail store, somebody comes in, you're not going to be rude to them, and you're not going to, try to sell them something just because they come from a culture that you don't understand. So you have to kind of meet people where they're at. Very social workish language, but it's the truth. Got to meet people where they're at, and that way, I think you make an impact of spreading the word that these issues are happening. That's how you have to look at them, and culturally, we have to be very mindful where people are coming from, and strip ourselves of our own values, because it has to be about the work, not about what you think.
It's time for pizza.
I think so.
Okay.
Is it like the Oscars? No.
Anyhow, first of all, I would like to thank very much our panelists, Kriti, Rama, Miriam, and Nadia. And what I really appreciate in the fact that we examined, and of course we did not exhaust all aspects of this issue, but we examined it both from the global as well as from the local perspective, both with data and looking at trends, as well as through examining some very personal stories, powerful stories. So I want to thank you for being with us this evening and for contributing to this ongoing conversation. I want also again to thank our co-sponsors, the Gender Studies Program, in particular my colleagues Rosemary and Sam, and last but not least, the indefatigable staff at the center, Aferdita, Marina, Yamna, Kathy, and Anna. I hope I didn't leave anybody out. I would like to make a couple of program notes. For us, the conversation is continuing, and our next event in this series is going to feature Alan Keller, who is a professor of medicine at the New York University School of Medicine and director of the Bellevue New York University Program for Survivors of Torture. I don't know if you're familiar with the work of that program, but it has been at the forefront of basically dealing with the effects of torture on the victims. And he has been doing that for a long period of time. In addition, Alan Keller oversees bioethics education at NYU, something that more medical schools should be doing work on, because it is kind of relegated to the margins of medical education. So he will be talking to us on March 20th. The event will take place at the Graduate Center, and we're going to post notices on our website, and you are going to receive notices, all of you, on our listserv. And the title is The Horror and the Hope. A documentary on the 17th of April. This is going to be here at John Jay. A colleague of ours from William Patterson University, Professor Gina Guerrieri, a noted documentary filmmaker, is currently preparing a documentary on depression. And it is going to have its world premiere here on our campus before it makes the rounds of the festivals. And she's hoping actually to submit it to Sundance. And I have to say that this is a labor of love, because all the people, or most of the people that have been involved in this documentary, are themselves suffering from some kind of mental illness. So it is a labor of love as well as a cathartic experience. And I very much hope that you'll be able to join us for the showing of this documentary, as well as the discussion that will follow with all those who are responsible for creating this documentary. last but not least, I want to say something about our students here at John Jay. Of course, you know there is the counseling department that you can go and discuss some of these issues, but I don't know how many of you are aware that there is a very vibrant student group here on campus. NAMI on campus at John Jay, that is the local chapter of the National Alliance on Mental Illness. And it's a group that is doing some very interesting work and is headed by a very brave group of young people with whom we organized a session last semester, and they themselves walk us through all the different phases of their own illness and how they try to cope with that. And I'm saying that because very often students feel very uncomfortable going to some kind of an authority figure to talk about their problems. If there are any issues, I want to let you know that they are fellow classmates of yours that are facing this challenge, and they are eager to help you. So if you don't know or you have not connected with this group and you want to find out more about this, I would encourage you to do so. It's called again NAMI on campus at John Jay. Okay, so we've had quite a bit of intellectual conversation tonight, but we should not forget, and there is some other aspect of human rights, which is the satisfaction of certain basic human needs. Health, of course, is one of them, but the right to food is another. So please join us for a pizza, which is waiting outside, and we can continue the conversation. So thanks again to our presenters and to all of you for being with us.